Welcome. Today, we will explore one of the most trusted designs in research, the Randomized Controlled Trial, or RCT. Have you ever wondered how researchers know if a new treatment really works? Let's find out.
What is a randomized controlled trial or RCT? A randomized controlled trial, or RCT, is what we call a true experiment. In this design, participants are randomly assigned to different groups, usually one that receives the intervention, like a drug or a therapy, and another that receives either a placebo or the usual standard of care. This approach helps researchers test whether an intervention truly works by comparing outcomes between these groups over time. RCTs are considered the most reliable type of clinical study when both randomization and double-blinding are applied, ensuring that results are unbiased and reliable.
When is RCT used? Randomized controlled trials are best suited for explanatory research, where the main goal is to understand cause and effect relationships. This design is used when researchers want to test whether an intervention truly leads to a change in outcomes. RCTs work best when the study involves a limited and clearly defined set of independent variables that can be manipulated or controlled, such as a specific drug, educational program, or procedure.
Steps in conducting RCT. A randomized controlled trial follows several key steps that make research systematic, unbiased, and reliable. It begins with protocol development, which serves as the blueprint of the study. The protocol outlines the objectives, methods, and evaluation plan, helping to reduce bias and maintain consistency. Next is selecting the study populations. Participants must give informed consent, meet eligibility criteria, and be available for follow-up, ensuring they truly represent the target population. Randomization comes next and is often described as the heart of an RCT. Participants are randomly assigned to either the study or control group, which helps eliminate bias and balances factors that could affect outcomes. Then comes the intervention or manipulation, where the researcher deliberately applies or removes a factor, such as administering a drug or introducing a new treatment, to observe its effect. During follow-up, both groups are monitored at regular intervals under the same conditions. This allows researchers to track progress and collect accurate and consistent data. Finally, there's the assessment, where outcomes are analyzed and compared between groups to determine whether the intervention made a meaningful difference. Together, these steps make randomized controlled trials the gold standard for testing interventions and improving patient care.
Strengths of RCT. Randomized controlled trials are often called the gold standard of research because they provide the most reliable evidence on whether a treatment or intervention truly works. A well-designed RCT with strong methodology offers high internal validity, meaning the results accurately reflect the effect of the intervention, and can also achieve acceptable external validity, or generalizability, to other settings. This high level of validity is achieved by protecting against both random and systematic errors, which helps reduce bias. Randomization plays a key role here. It balances both known and unknown confounding factors between groups, so any difference in outcomes can be confidently attributed to the intervention itself. Additional strategies, such as allocation concealment and blinding of participants and researchers, provide further protection against bias and strengthen the study's reliability.
While RCTs are considered the gold standard in research for establishing causality, there are limitations that should be noted. Ethical issues can arise particularly when randomization means withholding a potentially beneficial treatment to the subject. RCTs are costly to carry out and can be logistically challenging due to large sample sizes and long follow-up periods. RCTs involve complex coordination of participants and research staff and demand strict adherence to standardized protocols. FIC can limit the feasibility to carry out the research. Another key concern is generalizability, as highly controlled environments don't always reflect real-world conditions. Attrition or participant dropout, which is out of the researcher's control, can skew the results, especially if it's not balanced across the blind and controlled group. Finally, blinding is a major challenge in trials involving visible interventions, which can introduce bias.
In randomized controlled trials, validity is essential to ensure that the results we obtain truly reflect the effect of the intervention being studied. There are two main types of validity we focus on: internal and external validity. Internal validity refers to how confident we can be that the outcomes are actually caused by the intervention and not by other factors. It depends on how well the trial is designed and executed. External validity deals with generalizability, whether the findings can be applied to other populations, settings, or real-world practice. To achieve strong validity, several key assumptions must be true. First, randomization must be properly executed to ensure both groups are comparable at baseline. Blinding must be maintained so that participants and researchers are not influenced by knowing which group received the intervention. Also, protocol adherence is critical. Participants need to follow the assigned intervention, and researchers must consistently apply study procedures. There are several threats to validity that can compromise results. Selection bias can occur if randomization fails or if certain participants are systematically included or excluded. Attrition bias occurs when participants drop out unevenly between groups, leading to imbalanced data. Performance and detection bias can occur if care is different between groups in the study. These factors determine the overall credibility and applicability of RCT findings. Ensuring strong validity is what allows us, as nurses and researchers, to confidently translate trial results into evidence-based practice. In this hypothetical example, we will explore an RCT that investigated the effectiveness of mesenchymal stem cell injections on knee osteoarthritis. Background: knee osteoarthritis is a complex degenerative disorder that leads to pain and disability. Traditional non-surgical treatments such as physical therapy, medication, and injections of corticosteroids or hyaluronic acid often provide limited relief for advanced cases. Mesenchymal stem cells have been shown to repair cartilage and improve function in previous clinical trials. However, evidence of benefits in severe knee osteoarthritis remain limited. Research question: do mesenchymal stem cells intra-articular injections improve pain and function in adults with grade 4 knee osteoarthritis? This RCT was registered with clinicaltrials.gov. Funding was attained through the University of Toronto Research Fund. Ethics approval was granted by the University of Toronto Research Ethics Board. Written informed consent was obtained from all participants. This study was a double-blinded parallel group randomized placebo-controlled trial. Participants were randomly allocated using a 1-to-1 ratio to either the intervention mesenchymal injection group or the control normal saline injection group. Randomization was computer-generated and carried out by staff involved in the study. Participants and outcome assessors remained blinded throughout study. This was a single-center study carried out at St. Joseph's Healthcare Centre, Toronto in the Department of Orthopedics. 20 participants were used in this RCT. Inclusion criteria included adults aged 50 to 75. Diagnosed with unilateral grade 4 knee osteoarthritis as per the Kellgren-Lawrence scale confirmed radiographically. Failure of non-surgical management for at least 3 months. Exclusion criteria included prior knee replacement or major surgery, prior intra-articular injections of corticosteroids, plasma, rich platelets, or hyaluronic acid within the last 3 months. The intervention group received 1 intra-articular injection of 25 million mesenchymal stem cells taken 2 months prior from the bone marrow of healthy donors. The control group received 1 intra-articular injection of normal saline. All injections were ultrasound-guided and performed by an orthopedic surgeon. The primary outcome was patient-reported pain, function, and stiffness measured by the Western Ontario and McMaster University Osteoarthritis Index at 1, 3, and 6 months post-injection. Data were analyzed using an intent-to-treat analysis, and between-group comparisons are presented as 95% confidence intervals and p-values. All 20 participants completed the study. 10 in the intervention group and 10 in the control group. 4 participants developed localized infections managed with oral antibiotics. 2 in the intervention group and 2 in the placebo group. While the baseline overall scores for both groups were similar, the results indicate that the overall scores for the control group remained fairly unchanged over 6 months, while the intervention group increasingly improved over 6 months. The p-values at each follow-up demonstrate statistically significant differences in scores between groups.